Hello, I'm Dr. Christopher Thompson from Boston, Massachusetts. I'd like to thank Dr. Eduardo de Mora and the course organizers for the opportunity to participate in this very interesting session. And my topic is metabolic endoscopy, the next hotspot. Here are my disclosures. I'd like to start the talk by discussing some background on metabolic disease and pathophysiology, and then move on to endoscopic approaches to treatment. So what is obesity? Well, here is an enhanced scanning electron microscopy image of adipose tissue from a patient with obesity. And here we see adipocytes, and around those adipocytes are activated macrophages. So obesity really is a state of chronic inflammation of the adipose tissue. This slide illustrates the differences between healthy adipose tissue and adipose tissue seen in obesity. On the left, we have normal healthy adipose tissue with M2 macrophages and other cells secreting innocuous cytokines such as IL-10, IL-4, and IL-13. However, on the right, we see this chronically inflamed adipose tissue seen in obesity, and we have mast cells and activated macrophages and apoptotic adipocytes, and these secrete adipokines such as leptin, adiponectin, resistin. We have cytokines TNF-alpha, IL-6, and IL-1 beta, which are, of course, very toxic. They circulate throughout the systemic circulation and cause all sorts of obesity-related inflammatory conditions. This includes liver disease, and of course, diabetes, and vascular diseases, among others. And those circulating toxic cytokines, of course, contribute to metabolic syndrome, which is diagnosed as at least 3 of these related conditions: elevated blood pressure, a low HDL, elevated glucose, diabetes, enlarged waist circumference, of course, associated with obesity, and elevated triglycerides or liver disease. So these are the conditions that we're thinking about in metabolic syndrome, and it's very, very prevalent throughout the world, really, as high as 35% in North America, 34% in South America. You even see it, of course, in the developing world, in Asia, and really across the globe. It's becoming an increasing problem. And one thing that we think ties this all together is insulin resistance. Of course, one of the primary actions of insulin is to stimulate glucose uptake by causing translocation of the glucose transporter GLUT4 from intracellular storage to the plasma membrane. However, it also promotes the uptake of fatty acids and causes lipid synthesis. And it also directly controls the activation of a set of metabolic enzymes by a series of phosphorylation, dephosphorylation events that regulate the expression of genes encoding hepatic enzymes involved in gluconeogenesis, as well as stimulating amino acid uptake into the cells and protein synthesis via mTOR pathways. So insulin is very important in all of these functions, really opening up the cell. And you can see how insulin resistance could really cause a lot of problems. There's also some evidence suggesting the small bowel may contribute to this disease process. Mucosal hypertrophy of the proximal bowel is seen in some patients with obesity and metabolic syndrome. There's also increased small bowel permeability and tight junction alterations seen in some patients with NAFLD, and it's thought that these proximal small bowel changes may be associated with altered hormonal signaling, which could contribute to insulin resistance in obesity and metabolic syndrome. Now, shifting gears to treatment options, surgery is, of course, rather effective at inducing weight loss, and there's several different types of procedures, those that focus mostly on the stomach, and then, of course, those that involve an element of bowel bypass. And these are thought to have different mechanisms of action, with the procedures that involve the bowel bypass having a larger direct metabolic impact. We're now going to discuss 2 studies that really highlight the effectiveness of metabolic surgery. And the first is the STAMPEDE trial. This was a 3-arm randomized controlled trial from the Cleveland Clinic. And 3 arms included medical therapy, sleeve gastrectomy, and gastric bypass. And the primary outcome was treatment success at 1 year, defined as the hemoglobin A1C of less than 6%. These are all relatively poorly controlled diabetics. So the results here: only 12% of the patients in the medical therapy arm achieved that goal, where 37% of the sleeve gastrectomy patients did and 42% of the gastric bypass patients did. So, very very interesting results here. And in that same issue of the New England Journal, there was another paper from Italy. And this again had 3 arms: medical therapy, gastric bypass, and biliopancreatic diversion, so a longer limb bypass. And they randomized 60 patients to this study. And you can see the primary outcome was success at 2 years and is defined by an HbA1c of less than 6.5%. No patients in the medical therapy arm achieved that goal, while 75% of the gastric bypass patients did and 95% of the BPD patients did. To understand how these procedures work, it's helpful to understand the incretin effect. Here you can see on the y-axis we have insulin production, and on the x-axis we have time. And the line in red here is the amount of insulin production you get when glucose is given intravenously. When you give that same amount of glucose orally, patients produce far more insulin. And this is the incretin effect. It's thought to be due to the release of various hormones from enteral endocrine cells in response to food, short-chain fatty acids, and bile. And in type 2 diabetes, this effect is rather blunted. And kind of one of the goals of surgery, metabolic surgery, is to reconstitute this normal graph. However, incretins do far more than just increase the production of insulin. In particular, we have GLP-1 here. You can see it crosses the blood-brain barrier to increase the sense of satiety and fullness. It can slow gastric emptying, decrease glucagon production, and do a variety of other things as well. Another important concept to understand is the foregut and hindgut hypotheses. And here you can see the bowel, and the white dots represent incretin-producing cells, and they get denser the lower down you go in the bowel, into the ileum and even the colon. And the dark dots represent an unknown anti-incretin factor, and there's several potential candidates there, but it's not well understood. So a rule-wide gastric bypass works on both these pathways. It upregulates the incretin-producing cells, so that's in response to bile, secondary bile acids getting into that bowel, and as well as undigested food, and it downregulates anti-incretins by shunting food away from the proximal bowel. And now for the second half of the talk, we're moving into our endoscopic, bariatric, and metabolic therapies, or EBMTs, which we're hearing a lot of today. They can be broadly classified into 2 categories: gastric small bowel devices, with, of course, our space-occupying devices, gastric remodeling procedures such as ESG and plication, outlet obstruction devices, and aspiration therapy, making up most of these gastric procedures. And they treat obesity first and foremost, triggering weight loss with some secondary metabolic effects. And then our small bowel therapies, which include various liners, duodenal mucosa resurfacing, and anastomotic technologies. And these are thought to have very direct metabolic effects with a smaller amount of weight loss. Regarding mechanism of action, the gastric devices are thought to work either by creating a sense of restriction or potentially delaying gastric emptying. And in some cases, they may even make gastric emptying more rapid and then trigger downstream effects due to increased GLP-1 and causing satiety. And these devices have been shown to improve hemoglobin A1c and fibrosis scores. However, the question is whether that's due to weight loss or if there's another direct mechanism at play. And the small bowel devices really are targeting specific mechanisms. You have duodenal mucosa resurfacing, which is working on foregut mechanisms, anastomotic technologies, which are working primarily on hindgut mechanisms, and then liners, which really are trying to work on both of those pathways. We will start with the duodenal and jejunal bypass liner, and you can see here that it's trying to do the same thing that the gastric bypass does, sheltering the duodenum from food, down-regulating these anti-incretin signals, and dumping bile and food kind of unmixed into the distal bowel, augmenting the incretin signal. You can see what the device looks like here. There's a ring of tissue anchors and then the liner. This is placed over a wire and under fluoroscopic guidance, rather straightforward. And these are the results of a meta-analysis looking at clinical outcomes of the device. And you can see it at explant. There's a 1.3% decrease in hemoglobin A1c, which is rather encouraging. Additionally, in that same meta-analysis, there was substantial weight loss at 19% total weight loss. And this is keeping in mind in a cohort of patients with diabetes and obesity. So there's many different types of studies that were done with this. It seems quite successful in that population. In a pivotal study in the United States, the trial was stopped due to the formation of hepatic abscesses. And they thought that might have been due to the high-dose PPIs and some various other things that have now been modified. And that trial is, again, underway. Next, we have duodenal mucosal resurfacing, and this is the results of some proof of concept procedure development. You can see we have a catheter that is advanced over a wire under fluoroscopic guidance into the small bowel. There's these little channels that ride over this balloon. Tissue is aspirated into the channels, and a needle is passed into the submucosal space, and then a fluid cushion is created. This protects the pancreas and deep structures against the thermal ablation that occurs as you heat the water in the balloon. And this ablation occurs between the ampulla and the ligament of Treitz. And you can see here what the normal duodenum looked like at time 0 in these porcine studies. And then there's a rather thorough ablation that occurred. And then eventually it does come back to look relatively normal again here. But we do believe that this resets the duodenum and it has more durable lasting effects. Now this works primarily on foregut mechanisms, kind of silencing anti-incretin signaling. There's other nuances to the mechanism, but this is a general concept that may be applied. A first-in-human study was then performed in Santiago, Chile. That was a single-arm study. All patients had type 2 diabetes. BMIs weren't terribly high at 30.9, but they did have poorly controlled diabetes with an average HbA1c of 9.5. Across the entire cohort, there was a 1.2% reduction in HbA1c at 6 months, and this persisted after mucosal healing was documented on biopsies. And if you looked at patients with stable background medications, that reduction was actually 1.8%, so quite a strong efficacy signal. The Revita 1 trial then was expanded to Europe. Again, very similar patient population here, and you can see there was substantial improvement in HbA1c, fasting blood glucose, HOMA-IR, and liver tests. Additionally, they looked at liver fat, and you can see that there's a 30% reduction in relative fat and a 6% reduction in absolute fat in MR-PDFF. And finally, we have the Revita 2 study, which was a randomized sham control study. 11 centers, 9 in Europe, 2 in Brazil. And you can see the primary outcomes were HbA1c at 24 weeks and liver MRI on PDFF. And patients, very cohesive group here. And you can see in the European group, there was a substantial reduction in HbA1c between cohorts. However, not so much in the Brazil group. And similarly, in that European cohort, there was improvement in liver fat as well. There's another device under development that does laser ablation from Diagon. This uses a laser to block the duodenal submucosal neural plexi, thereby modulating the GI neural hormonal axis. The device fits through a working channel of a standard endoscope. They did a pilot study, 9 patients in the Czech Republic. You see kind of early obesity and poorly controlled diabetes and metformin, and there was improvement in the HbA1c from 9.3 to 8.1 at 6 months. So very early results, but we'll keep an eye on what develops there. And finally, we have enteral diversion, and you can do this with various devices, but typically it's done with magnets. You can see here in this particular approach, a scope is passed from above down to below the ligament of Treitz, and another scope is passed from below above the ileocecal valve. Then the 2 magnets are passed through the channels, and they are coupled. And then you have tissue necrosis that occurs here in tissue remodeling around the magnets. The magnets will then pass in the fecal stream, and you'll have a side-to-side anastomosis. So it looks like coming out of the channel, and then you need fluoroscopic guidance, of course, for this. And mating the magnets there. We'll pass. So here we have a treatment path where food directly enters the ileum and a preserved native path that mitigates against the complications. And this functions primarily on high gut mechanisms, as we're not really touching the duodenum in this early iteration of the procedure. These are results of the single-center pilot study in the Czech Republic with 10 patients. 3 had prediabetes, 4 diabetes, was performed with laparoscopic supervision and assistance. You can see the patients with diabetes, their A1C dropped from 7.8 to 6 at 3 years, and the pre-diabetics dropped from 6.1 to 5.2 at 3 years. So very durable results, and these anastomoses were quite robust. It also has substantial weight loss, about 14% total weight loss at that 3-year mark. So this device is now really being performed or utilized laparoscopically, but they do have other endoscopic iterations on the way. In conclusion, gut hormones play an integral role in the pathophysiology of type 2 diabetes, NAFLD, obesity, and other metabolic disease. Small bowel procedures targeting the mechanisms are proving to be effective in the treatment of these conditions. And it's important to understand mechanisms of action and how these devices work, because procedures that rely on different mechanisms will likely help to optimize combination therapies and give us better results in the future. Thank you for your attention.